Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington, and I wanted to talk about one of the interesting implications of the PACIFIC trial, which is an immunotherapy study done in locally advanced or stage 3 non-small cell lung cancer that has been a really important breakthrough that was the subject of a publication in the New England Journal of Medicine and also was the leading presentation at the ESMO 2017 meeting, and it focused on the addition of a year of the immune checkpoint inhibitor durvalumab, also known as Imfinzi, for a year after patients had completed chemo concurrent with chest radiation for stage 3 unresectable non-small cell lung cancer. And this study demonstrated a very significant improvement in progression-free survival that we haven't yet seen the results in terms of overall survival yet for, just because the study is still ongoing. But the huge difference in progression-free survival that is sustained out at 12 and 18 months at least is enough that it is very likely to become our new standard of care for patients with locally advanced non-small cell lung cancer. And I would say that it's extremely likely that this will also translate to an improvement in overall survival. Whether that is sustained at 5 years and beyond and represents true cures, I can't say. But this prolonged and highly significant improvement in progression-free survival, I think, is almost certain to improve the overall survival results at 3 or 4 years out. So this is likely to become a new standard of care. But what is also interesting is the implications it has in how we treat even patients who might be potential candidates for surgery. And so to back up, patients with stage 3 locally advanced non-small cell lung cancer are a pretty heterogeneous collection of patients who may have bulky disease or less bulky disease. And one of the most important variables is how extensive their lymph node involvement is in the mediastinum, that is the space between the lungs and the chest. And patients with stage 3A disease, which is limited to mediastinal nodes on the same side as the main tumor itself, are possibly candidates for surgery. And this really depends on the bulk of the lymph nodes and how many lymph nodes or lymph node areas in the chest are involved. And this is interesting because patients with stage 3A disease who would potentially be candidates for surgery or a non-surgical approach, I think are going to be increasingly considered as perhaps better candidates for a non-surgical approach with chemo and concurrent radiation followed by immunotherapy, now that this approach with immunotherapy looks like it's going to lead to significant improvement in outcomes. In the past, and we're going back to data from the last 5 and 10 years, trials that have compared patients who are possible candidates for surgery with locally advanced disease has shown that the results are very comparable whether we pursue an initial approach of chemo or chemo and radiation followed by surgery, or a more extensive chemo and radiation concurrently without surgery. So if we know that patients can be kind of on the bubble for whether they should have surgery or chemo and radiation without surgery, and this is before the introduction of immunotherapy, now that we have immunotherapy in the mix for the patients who are treated in a non-surgical way, it is likely to tip the scale, and I think that we are likely to see more and more patients who might arguably be candidates for surgery, be considered as better served by being treated with chemo and radiation concurrently followed by immunotherapy. This is important to consider because many patients and perhaps too many doctors think that surgery is definitely the way to go if you possibly can, and that chemo and radiation is some consolation prize. But in fact, with the results really being comparable even before the addition of immunotherapy, it's very possible, and I would say even likely, that more patients should now shift to a non-surgical approach that includes the immunotherapy portion and may well do better than they would have with a surgical approach. In fact, the question or the definition of locally advanced disease as unresectable is a kind of challenging one, because I was recently discussing with some of my colleagues that this issue of what is resectable or unresectable is a pretty subjective one that depends on the judgment of the surgeon and the motivations of the surgeon and the patient. And really, you know, if you have weak enough judgment, just about any patient may be considered resectable. That doesn't mean that it should be done, even if it could possibly be done. But I think that what we will see now is more of a welcoming of these patients with locally advanced disease to an approach that withholds the surgery, pursues concurrent chemo and radiation, and then follows that by the planned year of immunotherapy. We're going to learn more about this in the future, and of course we need to see the overall survival results from the Pacific trial, and in the future I think other studies as well. But we are just beginning to feel the implications of just these early results with the Pacific trial, and this will certainly have bigger implications in the future for how we manage this big field of locally advanced non-small cell lung cancer.